Welcome. In this video, we're going to talk about our chest pain case, and we're going to get some expert advice from Dr. Mahadevan, who's joined us today, to kind of go through the case. He's the director of the Stanford Emergency Medicine International Program. Welcome, Dr. Maha.
Thanks, Dr. Strela.
Let's get started.
Susan, we got a chest pain here. Trauma two's open.
Patient complained of a mid-throat chest pain, diaphoretic, vomited twice, sublingual nitro, 2 mg morphine. Says he's a doctor. Sir, are you... Oh my God. Dr. Kaysen.
Dr. Lewis.
You too.
So Dr. Maha, we have this 50-year-old gentleman who presented with chest pain. And he's a little bit sweaty, he's vomited 2 times, and the paramedics brought him in saying that he had been given some nitroglycerin and some morphine. How do you approach a patient like this?
Well, first you want to start with the ABC. So in this particular case, you want to look at the patient's general appearance and assess their level of consciousness, and then follow that by an assessment of their airway, breathing, and circulation.
And when you see a patient like this, is there anything that goes through your mind, like these are the main things that I have to watch out for? Or?
Certainly anybody who presents with acute chest pain that's kind of sweaty and diaphoretic, obviously an acute coronary syndrome is going to be one of the first things that you're going to be worried about. Other worrisome causes of chest pain in a patient of that age include things like pulmonary embolism, acute aortic dissection, and pneumothorax.
And a pneumothorax. Okay.
So you have
Run a 12 lead.
You didn't have
The hell is Steinman?
Tachy 120 risks 24.
Where are his blood results?
What's the EKG say?
So right away they got an ECG. How quickly do you generally try to get ECGs in your patients?
Generally, in someone who presents with acute chest pain, you want to try to do the ECG as soon as possible, but as a rule of thumb, within 10 minutes of arrival to the emergency department.
Okay, well here's the ECG. Do you want to take a look at it for us and tell us what you think?
Sure. This is a 12-lead ECG, and the patient is in sinus rhythm. What is immediately noticeable is that the patient has ST elevations, both in the inferior leads. So if we take a look in leads 2, 3, and AVF, the inferior leads, we know that the patient has some ST elevations, as well as ST elevations anteriorly in leads V1 and V2. And also of note is that the patient has some ST depressions in the lateral lead. So if you look at lead 1 and AVL, you can see that there's some ST depressions, and that's also true in lead V6.
So that's a pretty abnormal ECG.
It's a very abnormal ECG, very concerning, and demands immediate attention.
ST elevation in the inferior leads.
I'm gonna die.
You are not going to die.
This patient now, so we have this patient who is got a concerning ECG and looks like he's got some signs of shock. He's sweaty and diaphoretic. At this point, what kind of treatment would you start on a patient like this?
In situations like this, we always want to start with the ABCs, as I mentioned, and in terms of therapy, sometimes we need to act before we have all the information, and so in this particular case, we're going to start with oxygen. We can put 2 liters of oxygen on by nasal cannula. We can establish an IV in this patient that allows us to give IV fluid if we need to, or intravenous medications, and then finally, we want to place this patient on a cardiac monitor. Someone with an acute MI, acute myocardial infarction like this patient, is at risk for bradyarrhythmias or tachyarrhythmias, and so we'd like to put them on a cardiac monitor as well.
With this patient being diaphoretic, would you give him IV fluids at this point, or would you hold off?
That's a very good question, and I think the way to answer that question is to do a quick assessment and determine the patient's volume status. Patients with the kind of ECG that we saw, with inferior and anterior ST elevations, might have an MI, an acute myocardial infarction that involves their right ventricle, in which case what you'd want to do is provide them preload, and you may want to give them IV fluid. In some patients, they may be having an acute MI and they may be in cardiogenic shock, and in which case, and that might be involving their left ventricle. In that particular case, you want to provide them support, or you want to provide them inotropic support as opposed to just volume. And so you would do an assessment of the patient, listen to their lungs, make sure that they weren't in congestive heart failure before making that determination.
Yeah, so you mentioned that if the patient has signs of potentially a right-sided MI, that you'd be concerned about giving the patient a vasodilator like nitrates.
Absolutely. One of the first therapies that's given to anybody with chest pain and concern for an acute myocardial infarction or unstable angina is nitroglycerin. And you have to be careful in a patient with right ventricular infarction, because in that patient they may drop their pressure and develop shock as a result of getting a nitrate. And one way to determine whether they're having a right ventricular infarction is to place the ECG leads on the right side and look at the right side of the heart.
Is there any other studies you want to get pretty early on in this patient?
Definitely. You'd like to get some point of care testing done. Some tests that you'd like to do right out of the gates would be things like a troponin or cardiac enzymes to determine to confirm your diagnosis of acute myocardial infarction, CBC, electrolytes, coagulation studies, and a chest x-ray, maybe some things that you would want to start with. In addition, given the fact that the patient is likely having an acute myocardial infarction, other things to consider in terms of therapy would be giving the patient a baby aspirin as well, especially if they could take it orally.
Okay, so considering an aspirin, we're going to hold on the nitrates on this patient because of his ECG.
Absolutely.
Okay, well, here's the patient's chest x-ray. Do you want to tell us what you think of that?
Sure. The lung fields look normal. I don't see any evidence of fluid overload. The heart size is also normal. I don't see any evidence of cardiomegaly. And if you look very carefully, you can see the lung markings go out to the peripheries. So no suggestion of a pneumothorax as mentioned earlier. So in this particular case, a fairly normal looking chest x-ray also. The mediastinum looks fairly narrow, which doesn't exclude the diagnosis of aortic dissection, but makes it less likely.
Now, I've heard you talk about aortic dissection before. Is there anything else you look for on chest x-ray to help you identify aortic dissection?
You can look for widening of the mediastinum. So if you see widening of the mediastinum, that would be a concern for an aortic dissection. Also, patients with type A aortic dissections can develop some fluid around the heart and get pericardial tamponade. However, in an acute setting, you may not see the enlargement of the heart that you may see in someone who's got a long-standing pericardial effusion.
Great.
No cardiogenic shock. Okay, ET2 7.0.
More respiratory down. Open up the IV. Try to Lindbergh.
Bolus 1 milligram atropine IV.
Color code?
It's falling, Susan. 60/35. Start a dopamine trend.
So this patient seems to develop worsening signs of shock with some bradycardia and hypotension with a blood pressure of like 60 over palp. The doctor caring for him gave some IV fluids and added some atropine, and it looked like some dopamine. Is there anything else that you would consider in this patient, or anything else you would do in this patient?
In the patient that was shown, looks like they got very sick, obviously went into bradydysrhythmia and cardiogenic shock as well. So in addition to the IV fluid, atropine, and dopamine, you might consider another agent like dobutamine, although you have to be careful in someone who's hypotensive in administering dobutamine to that patient, but that may be one other thing. The other thing to obviously consider in a patient with a bradydysrhythmia in the setting of an acute MI is acutely pacing the patient in order to provide them a rhythm and hopefully help them out of their cardiogenic shock.
And how would you pace them? Would you try to do a transvenous, or would you try to do a transcutaneous?
In the acute setting like this, you would set up for transvenous placement of a transvenous pacemaker, but the fastest, the quickest way to begin pacing the patient would be to apply a transcutaneous pacer to the patient while you're setting up to do a transvenous pacer.
The other thing I see a lot is people being unsure on how much fluid to give in a patient like this because they're worried because the patient's obviously having, some cardiogenic shock. So would you be aggressive with your fluids, like a bolus, or would you put a rate, or how would you do that?
In this particular case, since you're providing inotropic support as well as chronotropic support, it's important also to fill the tank and provide this patient with some preload. So in this case, I think giving a small normal saline bolus of 250 to 500 cc's would be warranted because the last thing you want to do is give them pressors and atropine without filling the tank. So a small bolus and then a reassessment would be warranted in this particular patient.
Sounds good. Sometimes actually I like to add some epi to these patients if they're not responding to dopamine, or if I don't have dopamine, some places don't have it.
Okay, 402 tubes in. Bagging.
All right, you may need a pacemaker.
Roddy's okay.
Yeah, let's get him upstairs now.
So they intubated this patient, they rushed him off. In a patient like this, I think we always think about the definitive therapy and trying to get the artery open. How would you try to go about that? Would you prefer to try to get the patient to cath, like a PCI, or would you go for more of a intravenous fibrinolytics?
It really depends, Dr. Strelo, on the setting that you're in. In a university hospital like Stanford, where we are able to take a patient to the cath lab 24 hours a day, 7 days a week, the best thing for the patient in a setting like that is to take them to the angiography suite and try to open up their vessel as soon as possible. If you're in a rural setting or a setting that doesn't have access to a cath lab, and it's going to take a long time to get them to a center that has a cath lab, then in that case you might want to consider using thrombolytic therapy in a setting like that, rather than waiting to take them to the cath lab many hours later. The most important thing is to open that vessel as soon as possible and restore circulation.
So if you're transferring the patient a long ways, you're probably going to give them thrombolytics first.
Absolutely, and these are decisions that you don't want to make alone, but you want to make in concert with your consultants, like your cardiologists. However, if you're alone, or if the transport time to the cardiovascular center is extended for more than 3 or 4 hours, obviously you're going to want to discuss it with the cardiologist at the other center where you're transferring the patient, and you may jointly decide to start thrombolytics in that particular patient.
And would you use any other anticoagulants as well?
It's controversial in terms of the use of other anticoagulants. Again, 2B3A inhibitors, aspirin would be the other, heparin would be the other things to consider in this particular patient.
Okay, heparin, 2B3As, and then an aspirin or some kind of antiplatelet agent, right?
Absolutely.
Okay, great. Well, hopefully we got this patient to PCI then, since it sounds like that was the preferred place to get him. And I want to thank you for coming in, Dr. Maha, and sharing your expertise with us on this case.
My pleasure.